Walking is the best medicine for peripheral artery disease. Doctors tell patients to walk, 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 but patients don't see the results. Why? Well, the doctors don't tell patients how to walk effectively to improve their circulation. I asked a doctor just recently during an interview to explain to patients how to walk effectively in order to grow their natural bypasses, to which he replied, I didn't know there was a specific way to actually walk. Well, it's no wonder why the number one most watched video through the Global PAD Association is Walking is Medicine. How to walk effectively to grow your natural bypasses. It had 22,000 views on patient comments saying how impactful it was on helping them to improve their circulation and prognosis. It was created by world-renowned vascular surgeon, Dr. Anahita Dua with Mass General in Boston, Massachusetts. So she is our very first award winner as part of the 2024 Global PAD Association Awards for the most impactful educational video for peripheral artery disease. Congratulations, Dr. Anahita Dua. We really appreciate you. I mean, when you created this video, did you ever imagine 22,000 views? It is viral.
That's incredible. I cannot believe it. And I think it really speaks to the point you were making earlier, that at the end of the day, patients need to be given more than just a command to explain why we're asking them to do what they're doing. And the fact that this video was watched so much, which is absolutely wonderful, just means that patients clearly are thirsty for that information. And what I know from it also, because you've been kind enough to update me, is it seems that patients are following the directions because they know why they're doing what they're doing. And that has led to results, which is really wonderful to hear. And what more can a doctor want?
I know I don't understand, why don't doctors explain to patients how to walk? We even had a recent amputee who said, if doctors only explained that I needed to push through the pain, I would have done that. But now I've lost my leg because I thought I was walking. I thought I was doing what I needed to do, but it wasn't enough. And obviously, I shared a moment ago that a doctor I interviewed said, what do you mean there's a way to walk? So why don't doctors know about this?
I think it's something, interestingly, that not all physicians are also taught. Different doctors have a little bit of a different way of asking patients how to walk. But the idea that there is a very calculated, strategic element to it is something that isn't really discussed. I'll give you another example where this happens frequently. Patients will be told, stop smoking. So what does that mean? And how does one stop smoking? It is an addiction, for example. It is something that really can, affect people's lives, and people use as a crutch when they're in stressful times. So it's very hard to just tell somebody, hey, stop it. And when you say stop it, do you mean stop all cigarettes right away? Do you mean let's cut back a little bit? What is the actual physiological process that would be most effective to stop something like that? And I think walking just falls into that category as well. People say, oh, just walk. But, you could get up from your chair watching Netflix and go to the bathroom once every hour, and technically you're walking, right? But obviously that's not going to make an actual impact. And again, I think the very crux of it has to be explaining the why, because the more you understand what and why you're trying to do something, the more it makes sense to you. Because people walk all the time. In fact, I tell my patients, hey, because they'll ask me, I go to the gym with my girlfriends and I get in the pool and I do jazzercise. That's exercise, because people think walking means exercise, because that's, of course, what doctors say, go and exercise. That is not at all what we're trying to have you do to get your collateral flow to grow. Or somebody might tell me, I've had this one all the time, I have an exercise stationary bike at home. Can I bike? Actually, no, because that works on your quads. That doesn't do what I need it to be doing to your calves, which are what squeeze and what get you to ultimately grow those collaterals to get all the way down your leg. And so I think having those conversations are fundamental. And sometimes with some physicians, they may not be themselves completely aware of what exactly they're asking you to do, or they know and they're just time crunched and just assume that potentially the patient knows, when clearly that's not the case.
And there are a couple of organizations out there that talk about, you got to move. You move it or lose it. And they say, even just taking the groceries, walking them up the stairs, walking back down the stairs, getting another set of groceries, walking back up the stairs and then down the stairs, like that's great for you. That's not going to do anything to actually grow your natural bypasses at all,
No,
right?
not unless those stairs are very long and you get some lactic acid buildup. The point is you have to, it depends on who you are. If you are walking up 4 stairs and you start to get the pain, and then you walk another 2 stairs and you just can't do another step, and you do one more, you've done something. But if you can go up and down the stairs, and really, most people, because of the way we grow up, most people associate, hey, walk up the stairs and, with get your heart rate up. Oh, if you're getting your heart rate up, you're doing something. So sure enough, don't take the elevator, take the stairs. But, and yes, absolutely do that. But that's a different thing that you're trying to do. If you are specifically walking as a medicine, if I'm prescribing walking to you, I'm asking you to do a very particular thing. If I hand you a bottle of antibiotics and say, go take antibiotics for your infection, you could potentially, kill yourself by accident, right? With an overdose. Or you could do it completely wrong and not have the effect of the medication or have a very partial effect. It's imperative that I, as the physician, say, take 2 with meals for the next 5 days. That's the prescription. So the way to think of walking is exactly that. I'm going to prescribe it as therapy. If I'm going to prescribe it as treatment, then I must prescribe it. And with that must come duration, way of doing it, and what's going to be the most intelligent way to actually allow it to be impactful. Because the other thing, I mean, we're Americans and we do not like exercise. Okay. We don't like the hard way because everything's so wonderful in this country. Things are meant to be easy. And so if something is tough, you're probably doing it wrong. So it makes sense that when you start walking and you start to feel the pain, you're like, whoa, 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 I'm going to break something. I'm going to hurt myself. Right? Maybe I'm doing this incorrectly because I'm feeling the pain. But if someone doesn't explain to you, actually, that's it working, you'll never actually know what you're supposed to be doing. So the onus is very much on the doctor to prescribe appropriately. And I think the way to get that message across is to say to the patients that when you're in the room with the doctor and they ask you to walk, that you ask back, could you please tell me for my specific situation what you mean by that? Because if you're a patient that has a horrible wound, let's say, on one of your feet, okay, and some doctor says, walk, 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 and you think, okay, I'm going to do it. I'm going to go walk for 3 miles today. And you come back with now a giant open blister that ultimately ends up in a situation that can't heal. You have clearly done the incorrect thing. And it goes back to that antibiotic example. Penicillin is a perfect and wonderful antibiotic for the right patient, for the right disease who's not allergic. If you hand a penicillin bottle to everyone who walks through the door, someone's going to have a bad result. So once again, treating walking like medicine, like therapy, is imperative. And really thinking of it as therapy allows patients to adhere to it. Because, as I mentioned earlier, we don't like the hard way. Who would? So if you're going to do it, if you're going to get to that point where your leg hurts and you're standing out there on the street and you're like, I just hate this, I just want to go home. If you know why you're doing what you're doing, that's going to make you go those extra steps. If you don't have a clue what's going on, you're not going to adhere to it. So that's extremely important.
How is the pain, and this, I get this all the time, how is the pain and the cramping that you get with PAD different than an athlete? Let's say when you're a teen, you get a muscle cramp in your leg and you need to stop to rest or else you will hurt yourself, versus with PAD, you get that cramp and you're not to stop because it's a good thing and it will actually help you to improve circulation to walk through it.
So there's 2 physiological processes going on. Take the athlete, okay? The athlete that you speak of running track meets gets a huge Charlie horse in their leg. Whoa, whoa, has to stop. Typically, in that situation, what's going on is that they may be electrolyte imbalanced. So they're not getting enough potassium or sodium, and they get a cramp because of that. Because the way muscles work, muscles are pretty stupid. They really can just contract and expand. And they get a cramp. And so when you have a situation where you have not enough electrolytes to make that actual movement, that can result in a tightening and a cramping of the muscle that is very painful. And if you don't let it just relax and open out again, you can actually rip the muscle off of the area it needs to be. So you don't want to do that. Now, that's not our situation. In our situation, the PAD patient that's walking and getting cramping, that's a totally different question. What's going on there is lactic acid buildup. So let me explain. Imagine that you're at the gym and you're doing a bunch of bicep curls, okay? You do 1, you do 4, you do 30, no big deal. Now you get to 35. Oh, it hurts, right? The bicep hurts. What does your trainer always say to do? Do 2, give me 2 more, give me 2 more. Why? Because if you're trying to build muscle, if you're trying to get those biceps huge, you need to do those extra 2 because that's when all the work is happening. Up until 37, you were just flying. It's no big deal. But it's those last couple, give me those extra 2. That's where you build the muscle because you break it down and you rebuild it. But that pain that you're feeling, that's lactic acid buildup. And you want the blood to come in and wash it away. So when you're walking and you have PAD, kind of the same thing is going on. You get a buildup of lactic acid in your legs and that crampy pain because not enough blood flow is getting to the calf to wash out all of the stuff that the cells are making to allow you to go back to a natural state. So similar to the bicep curls, if you're walking and now your leg starts to hurt, you need to do that, oh, give me that extra minute, because that's when you're going to be building those collaterals. The best way to put it, the way that I put it with my patients is, I want you to think of the county that you live in, okay? All of you, think of the houses that you're in. Imagine if you have a terrible road right outside your house. It's got a big pothole in it. And the city only has a certain amount of money to go and fix potholes in the state. Who's going to get that pothole fixed? I'll tell you. It's the person who's going to go down to City Hall and scream about it. That's the person who's going to get it fixed. So the same way, your body has a certain amount of energy, of nutrients, of stuff that it can go fixing things around your body. So the only way that your legs are going to get the attention of the rest of your body to allow it to come and build those collaterals is by screaming about it to the body. And how do you scream about it? You make it be in pain when you walk. So when you're walking, you're causing that pain. Your body's not going to like that. First day, it's going to be like, ooh, we don't like that. Second day, ooh. Third day, let's lay down some collaterals so that we stop this screaming. And that's the way. But if you just sit in bed or if you just sit on the couch all day long and you don't actually walk, the body's going to think, well, this person isn't even using this. We're not going to waste money fixing a pothole on a road no one's even driving on. That would be silly. And that's how, quote unquote, if you don't use it, you lose it.
And, if you're prescribing, and just, I know that there are also clinicians, physicians watching, how do you prescribe walking as medicine, and what is that conversation that you have with these patients in this clinic? And I know you went through some of it already, but just, you have a short amount of time with these patients. You're the physician, I'm the patient. Explain to me, I need to walk.
I say to the patient, there's data out there that shows that in a patient who is a claudicant, which is just a fancy Latin way of saying it hurts when I walk, if we go in there and we intervene on you, you fall into a different bucket. And we know from a lot of data that patients who get unnecessary interventions for something that they could have dealt with by just walking have a higher rate of bad outcomes, including amputation. So what's our job here? We want to keep your legs virgin territory. We do not want to get in there and start rotoring and sticking stents in there and balloons in there if we don't have to. That would be crazy. It's like taking a person who's perfectly well-shaped and doing liposuction on them unnecessarily. Someday when they may actually want it or need it, you've now created all this scar and caused all this trouble that procedure may not go as well as you want it to. It's a silly example, but that's the way I say it to people. So people get it. Yeah, okay, I get it. It's an unnecessary procedure at this point. Then I tell them, you can take care of this problem by yourself. And not only that, if you take care of this problem, you do the walking program and you create those collaterals, guess what? Those guys are with you for life. If I go in there and I rotor through something and I balloon it open, you're going to get maybe a year, maybe 2 years out of it. And then I'm going to have to come back and then come back again for another touch-up and another touch-up. But if you build those collaterals, you've now built things that are going to allow you to get that blood flow forever. And the vascular system is all connected. So you're also going to be benefiting your heart and your carotid arteries that deal with the stroke risk side of things. So overall, your chance of death from heart attack, from stroke, and the pain in your legs, we can make vanish by you doing this walking program. So now they're interested. Now I got them on the line. Then I say, it's easy. This is what you need to do for me. I need you to go home, and for the next 5 days, every day, I want 30 minutes of walking. And they say, what, 30 minutes? I can't even do 2 minutes without the pain. I say, I know. I'm not telling you to do 2 minutes. What I'm telling you to do is, over the course of 30 minutes, I want you to start walking. When you feel the pain, I want you to keep walking. And then I only want you to stop when you have tears in your eyes from the pain. And they laugh. And I say, but you get what I mean, right? And they get it. And then I say, then I want you to only rest for as long as you need to start up again. So I don't care in 30 minutes if you start and stop 500 times or if you walk a full 30 minutes. I just want you to do 30 minutes where you've really pushed yourself. And I want you to document, this is the key, how long you walk before the pain starts, how far you can walk once you have the pain, and then how long you need to rest before you get up and walk again. And if you document this, what you will find is patients will get really excited because within the first week, they'll already start to see their times increase. Oh, it's taking longer for the pain to set in. Oh, that means it's working. And then they get motivated. The same way you'd step on a scale if you were trying to lose weight and you saw you lost 5 pounds from eating salads. Wow, you can do another week of it. And that's what I tell my patients. And then I tell them, very rarely in medicine, very rarely, can I give you a guarantee on anything. But on this thing, I can guarantee you, if you don't smoke, okay, if you take your aspirin and your statin, and if you do this walking program the way I just described it to you, I guarantee you results. Why? Because multiple randomized controlled trials, which are the most powerful data trials that you can do, have come out that have clearly showed that for intermittent claudicants, again, which is people who have pain when they walk, if they do a supervised exercise therapy program, which is what this is called, a SET program, they do get a longer period of time where they walk before the pain sets in. Are you going to run the Olympics? Probably not, but you don't need to. What I try to tell them is, what I'm trying to do for you is I want to get to the point in your life when you get to go outside to the movies with your grandkids, whatever you want to do, and your legs are not on your mind. If that's the case, we've won. And that's what I'm trying to do. And they love it, and they go for it.
And we had a question that came in a little earlier. If you can walk 2 to 4 miles without claudication, should you pick up the pace to try and induce cramping within those 2 to 4 miles? This person has a 100% blockage through the SFA into the knee and a little bit below into the upper calf. The fact that they don't have any sort of pain or cramping in 2 to 4 miles, is that a sign that they're not walking brisk enough? Or is it just simply a sign that they don't have the lifestyle limiting claudication, that they're still, they're just asymptomatic, which is a good thing, that they've grown enough collateral vessels?
It can be both of those things. If you can walk 2 miles at a decent pace and not feel anything, you have won in life, my friend, and congratulations. Like I can't do that. Good job. So, but what I would say is most likely what you want to do in that case is you want to include inclines in your walking. So instead of, certainly pick up the pace, no problem with that. But the easiest way to trigger the crampiness, as you all know, is walking up a steep driveway, walking up a hill, right? And if you have a treadmill, just increasing that incline a little bit. And what I would suggest is doing that in exactly the same way, because you're going to get to that point. No matter where you start, you are going to, over time, be able to walk a lot further without the pain. And I guess the real question probably embedded in the question that was being asked is, when is good enough good enough? And the answer is, honestly, it depends on you. I have grandmas that couldn't make it out to their mailbox. That actually, I'm thinking of this one lady that now is like living her best life on a yacht in Florida with a new boyfriend, because we got her through the program and she did amazing. And then I had a guy once who, maybe in his 70s, but his wife and him had retired and they wanted to travel the world together. And their thing was that they would go on these extremely long hiking trips. Like I'm talking like 12 or 15 miles, which is, a lot. And he couldn't keep up with her. Basically, so it was affecting them. Now, and I said, but my God, you can go 10 miles. Like, you really, like, you want to do a little extra for, and he said, yeah, I can't keep up with her. And this is our thing. I said, okay, fine. Then let's make that happen. And so sure enough, we made an exercise program specific for them, which included a lot of inclines because we wanted to trigger earlier on. Now, you cannot call that lifestyle limiting claudication. Obviously, someone who walks 10, that's a person who's doing great. But in order to build that extra endurance, extra flow, I ask them to do this. So it really depends on what your own goals are. And that is something that you should set. So you'd say to yourself, listen, I got these 2 grandkids. I want to be able to go to the mall with them. And, you know, if one runs off, I want to be able to like chase after them and not have to sit down. That's my goal. Okay, how do we get there? And that's when you do the walking program and you build up to that thing. Somebody else might say, I want to do 1 mile around my block without stopping. Amazing. Then that's what you work up to.
A patient said in this question earlier, patients with intermittent claudication are told to walk, even if they're over 70 or over 80, as you were talking about. But it's an age time frame, they say, in which falls can be debilitating. If a patient ends up with a fall or ends up with being laid up due to a hip, knee replacement, or another procedure, will they lose their collateral vessels they've built and PAD symptoms progress?
That's an excellent question. Yes, that does happen. You're completely right. And the answer is actually in that particular situation, usually when you're laid up for like, let's take your example. Let's say a broken knee or a broken hip, okay? Assuming that you're otherwise healthy and that's not going to lead to like an ulcer on your back that ultimately may kill you. So assuming you're going to recover from this, okay? Most people are not, in this day and age, are not laid up for long enough that you would lose your collaterals. Because most people, even hip and knee breaking, or even a long bone fracture, your orthopedic surgeons are going to be getting you up pretty quickly. Are you going to be walking 2 miles? No, but you will be getting up and moving, and ultimately getting to the point where you'll be able to walk normally. And in that time, it is unlikely that you will lose collateral flow. What you will lose, though, is muscle mass, and that happens very quickly. That will happen literally. We have people in the house for like 2-3 days and they need a little bit. I mean, it's kind of like what happens to astronauts when they go out into space, and when they come back, they need to be like carried off the shuttles because of the fact that gravity hasn't been working on their bodies for a little while. So they like lose the ability because they atrophy some of their muscles. So really the key, if something like that happens where you're laid up somewhere, is you want to find like isometric exercises, which your physical therapist will tell you about. That includes like strength training and kind of using your own weight to maintain your muscle mass, which again is the same thing astronauts do when they go to space. It's actually the capsule that's supposed to go to Mars, to take people to Mars. It's like this big, but they want to make 50% of it like the workout stuff, because you have to maintain otherwise they'll not be able to even get off the thing. And so it's a really big deal, and it can happen really quickly. So I would say that is much more pressing than worrying about your blood vessels if that were to happen.
We get this all the time. How much walking is too much? We have patients that have developed knee, hip, as well as foot issues from walking, and even more walking. So what parameters should you set for an adequate walking regimen that does the job for PAD, but doesn't adversely impact other areas of the body during this valiant effort?
Great question. So I'll say a couple of things before I jump into just how much walking, because I'll say, how are you walking? What I mean by that is, if you're going to be, even if you had nothing wrong in terms of PAD, a person who's going to be taking on an exercise program, if you're going to the gym or if you're going to be walking outside, you need to have the appropriate footwear. And as a woman, let me tell you that we all know the uglier the shoes, the more comfortable they are and the better they are for you. So
that's so true.
It is true. It's totally true. So you pick the ugliest, most hideous diabetic foot shoes you can find, even if you don't have diabetes, because those shoes can be fit. They're a little expensive, I'll give you that, but they last and they protect. And a lot of you will have diabetes. That's actually part of what PAD, unfortunately, part of PAD. So you get those good footwear, really good footwear. Needs to fit right. You need to have nice socks that you're wearing. You never wear your footwear without socks, because you want to make sure you're not getting, many things can happen to your feet that are not, and you want to make sure you've got that nice sole platform so that you're not getting pain. And you're right, like people do get knee and hip pain, and a lot of it is sometimes referred pain from the feet because the footwear is not appropriate. You're not taking this walk in flip-flops, I'll say that. You're not taking this walk on a beach. You don't want to do it in terrain that's going to make you drop or that's going to make you stop. Right? You're not going to go outside and pet your neighbor's dog and then stop at the stoplight. It doesn't work like that. So a treadmill really is the name of the game, honestly, or a track or something like that, where you can be continuous and you can be kind of controlled. And so the answer to how much walking is too much walking really lies in making sure that you've optimized everything and that you reach the point where you feel like you have achieved over that 30 minutes everything that you, because most people on average will fall into that 30-minute category. I'd say walk for the 30 minutes, start and stopping. And if you get to a point in your life where you're walking a full 30 minutes at a decent pace without stopping, you've achieved it. Like, that's where you want to be. Because pretty much anything in life that you want to do, if you can do continuous walking for 30 minutes at a brisk pace, you could pack into that. You'd be able to achieve it. So that's what I would say as my cutoff, and that's certainly what I tell my patients.
Some say that if you can do 30 minutes, then you should do 45. And if you do 45, you should do 60. What is your thought on that?
I mean, I think that's getting into cardiovascular health and getting into, I mean, there's nothing wrong with that. In fact, that's great. Sure, do 45. But to your point earlier, I mean, are we walking all day here? You know, what is there has to be a point at which we say, so it has to come down to like, what are we really trying to do? When you have intermittent claudication, what you're really trying to do is you're trying to stress your body so it builds collaterals so that you don't have pain when you walk. That's what you ultimately are trying to do. And if you reach like a 30-minute walking at a brisk pace, you have done that. Anything beyond that certainly is extra. I see that question there. Does the initial 30 minutes include walking and resting time, or do you keep going till the total walking? No, it does not include your resting time. It's walking time. So it may take you an hour to do the 30 minutes.
That's actually really so, because I was on the impression that you set a clock for 30 minutes and you try to walk as much as you can in that 30-minute time frame.
Yes, but if you can't, so let's say, for example, you have a rest time period of 10 minutes, right? So let's say you walk for 5 minutes and then you have to stop and you take a rest for 10 minutes and then you do that again, right? And it's again another 10 minutes. That's 20 minutes now of your 30 minutes that you had to rest. So it's totally, it depends on where you kind of start with things, but I would ask my patients to proceed through that time frame all the way through, not feeling like that. I don't want, I mean, you don't have to be completely psycho about it. Like, oh my God, I have to add 30 seconds to, but if you are taking chunks of your time, I think as a good rule of thumb, longer resting than walking, then you should add on the extra time to finish the walking.
So the rule of thumb is 30 minutes. But if you are having, within reason, and that you're sitting there and you're actually sitting for a full 10 minutes and you're literally walking for 2 and then 10, I mean, come on, you need to push yourself a little harder, because walking 4 minutes or 6 minutes in a 30-minute time frame is really not enough.
Exactly right. That's exactly what I would say. And you'll know that. All of you know that. You know when, like, I'm not really doing this. Even I know, I go to the gym too, and I know when I'm slacking off, right? You really have to be, I mean, look, this sucks. It's not a nice disease. It's not a sexy disease that, like, it has a cure. And that's why you got people like me and people like Kim that are there to say, hey, we know this sucks. We're with you, right? But believe me, as a doctor, let me tell you something. The stuff that like really like hurts and makes you scream and makes you shout, actually that stuff's not what kills you. It's dramatic, but it doesn't kill you. This is the stuff that kills you. This is where you're in America today, trauma, cardiovascular stuff, and cancer are 3 big killers, right? And cardiovascular takes the cake, let me tell you. And it's not a dramatic thing. People are just not falling left. It's a slow, insidious thing that takes over your life, that takes away your quality of life, and ultimately puts you in a position where you get a stroke or a heart attack, and or an amputation, and that's kind of the end. And so it makes sense, as we all know, nothing that's worth it is easy. That something like this, where you want the durability of the treatment, you want this thing away out of your life, it's going to require a sustained effort, because remember, this is a chronic disease. This is not going to ever get cured. If you have PAD, whether you have it genetically or you have it because of diabetes or you have it because you smoke, it's not going anywhere. So what you're doing is you're trying to live your life so that you can, like, basically outlive the disease. That's what you're trying to do. So you're trying to get to a point where you control it and it doesn't control you. And the way you do that is by taking control of things like this and, not getting down about it. You got a bad lot in life, but it's at least something that can be managed, and it won't take your life if you are committed to something of this nature.
And I have a couple more questions, then we'll open it up to our live studio audience. If I have a wound on my foot, what do you suggest I do to build collaterals? Can I use a foot cycle at that point? Can I just push plates back and forth at that point and just to move? What do you suggest? I mean, you probably say, well, you have an offloader, but I guess it depends on the type of wound and how vast it is.
It really does. I would say if you have a wound of any kind, that requires, like, your vascular surgeon needs to, like, do not just go and start walking on it. That needs to be seen by a vascular surgeon, because that may need, getting a procedure is also not a failure. Like, it's not like, even an amputation, frankly, is not a failure. These are all treatments for certain disease processes. And intermittent claudication is one end of the spectrum. When you get a non-healing wound, even if it's an accident, like, you stubbed your toe, it's not like it just spontaneously, but you stubbed your toe. That needs to be seen by a vascular surgeon or interventional cardiologist or interventional radiologist, anybody who does this type of procedure, a vascular specialist, because it's really important that if you get a wound like that, it's managed quickly. What you don't want to do is try, I'm going to walk myself out of this, and you go and do it and you make it 100 times worse, because walking is not the treatment for critical limb-threatening ischemia. The treatment, surgically or endovascularly, to get more blood flow to your leg is the treatment for critical limb-threatening ischemia. So, the onus is not on you to have to figure out what's going on here. And let me give a little explanation about that. If you come to see me and you say, I have cancer, the next question out of my mouth is going to be, what type of cancer? Because it is so important. If you have thyroid cancer or skin cancer, that is a very different thing than pancreatic cancer or brain cancer. Now, we all know that. Everyone sitting on this call is like, yeah, thyroid cancer versus brain cancer. Like, I can't tell you the details, but I get it. Like, one is like, whoa, and one is, manageable, treatable, possibly. PAD is like the word cancer. And in PAD, there are two types: intermittent claudication and critical limb ischemia. And they are not the same thing. And it is a mistake of the medical community that we have been approaching this as PAD, which it is. That's the umbrella term. But knowing what you have is fundamentally important, because walking on a wound that has not got good blood flow is a disaster and can lead to amputation. But walking when you have intermittent claudication and it hurts when you walk in your calves, and pushing through that pain is the literal treatment for that. And in the same way, you wouldn't take thyroid cancer medication for a brain tumor, you shouldn't be doing walking for critical limb ischemia when you need a procedure. So having a vascular specialist guiding you through this is fundamentally important.
So you have the vascular specialist, they go in, they're able to open up as many vessels as they can, and in whatever way they can, they improve the circulation. So you're trying to heal the wound. Will the foot cycle help in the meantime until you can get back on your feet and start walking in an effective way to grow more collaterals to prevent yet another procedure?
You mean the little bicycle thing with the, you mean that?
With bicycle, or even, patients talk all the time. They're like, I don't understand why I can't use a stationary bike or a foot cycle.
I'll explain. So that has to do with what is firing in your body, what muscles are firing, what are you using? In the same way that, oh, you guys, excuse me 1 second. I am on call and I do have a call from the hospital. Will you excuse me 1 moment?
Sure, that is totally fine. And I can talk. So as she was saying that, we do get all the time, the question about, whether or not you need to just walk or whether you can do something else. And so many of the studies are just on walking as medicine, but what about the stationary bike? So she's going to talk a little bit more about that. Of course, if you aren't able to walk, you still got to actually think about your cardiovascular health. You're not going to die from your legs. You're going to die from a heart attack, right? And you can build collateral vessels around your heart just as you can in your legs. And so any sort of cardiovascular activity, anything you can do to safely to raise that heart rate and get that cardiovascular workout is really, really powerful and really important. So even if I was telling my dad had some struggles with walking after he fell and he broke his hip. And he was put on in a wheelchair for 2 months, and he was told you can't, even put non-weight bearing on that one leg. So we got him a foot bicycle that he used for his arms. So he was ending up using the foot bicycle for his arms to help get that cardiovascular health intact. So if you do have a wound on your foot, at the very least, think about your heart and get one of those foot cycles and use your arms to go ahead and get that cardiovascular workout in, because that's really important. And that will help grow those collateral vessels, around your heart. And we're going to ask Dr. Dua as well, if any of you wants to jump in and ask her instead of me, that's fine. But I definitely want her to cover what areas of the body can you grow collateral vessels and which areas of the body are not so good. I've been hearing that the iliacs have a tougher time growing some of those collateral vessels, but yet I'm curious what she has to say, because I think that Dr. Dua will give us a more definitive answer on that. I also want to address walking in water. We have several patients that say that, they'd love to walk more, but they do struggle with doing that on pavement or doing it on a treadmill. And they wondered if walking in water will help, because maybe that resistance that you get from the water will help build a little extra strength in your muscles, in your legs, so that maybe once you get out, you might be able to walk just even that much further, because you're building a little bit more muscle that Dr. Dua was saying, you do lose, especially when you're sedentary. So I was just going over some of the things that I hope to cover, ahead, but let's go back to you in terms of the stationary bike and even a little foot cycle. What is the difference? Again, I know you addressed this earlier, but just in a little bit more detail. What is the mechanism of action by which walking works and a stationary bike may not work to help improve circulation and PAD symptoms?
So a stationary bike, basically, again, your kind of your quads and your hips are moving, but your calves are not moving and your feet are not. So it's not the walking motion. And so you're not really developing, even if you were to do good things and, like, for example, a biker, if you just think of someone who uses a stationary bike, what you'll notice is like they'll have big, thick quads, because again, that's the area. And so a lot of times for our patients, the issue is getting blood flow down to the toes. So it's all that flow that you want to stimulate and to get little blood vessels forming down there. And you're just not doing that by using that. I mean, I guess a good example would be if you were doing biceps curls and expecting your leg to get better. I mean, it's a little bit of an absurd example, but it's a sort of the same thing. You're just firing a different muscle group to do the bike. Now, your question though is if somebody was like, did a procedure and now they have new blood flow and now they go back home and, while the wound is healing, they just want to maintain their physical strength and maintain, in terms of a physical therapy situation, then yes, absolutely. Being on the bike, because it's keeping your joints moving, it's keeping that muscle growth going. It's not that you're not getting blood flow to your legs. Of course you are. It's just not stimulating it in the same way that walking does, because you're not firing, again, those particular muscles. But once you would heal a wound, then you can go back to walking freely.
And what are your thoughts about walking in water? Water can provide resistance. It can help build strength. Is that something that you would consider as part of therapy for patients that say, you know what, I just can't walk that far on the land. Can I supplement my walking with walking in water? Will that help?
I would say no. Specifically, no, because exactly what you just said, I just can't walk that far on land. And the reason is because you want them to feel that pain. You won't really feel that when you're in water. Even if you were walking up and down laps, because you're exactly right. You'll get the resistance against your body, but you're not getting the gravity. In fact, back to the astronaut thing, they do most of their training on Earth underwater for that reason. So that's the issue with this stuff. It's good for some things, but it's not good for this particular thing at the end. And again, if we go back to like kind of the studies and the data, everything has been done with the interventional arm being walking on flat terrain. So I would say you can't supplement. I mean, you can do anything, but you need to do the 30 minutes on walking on land. And if you can't do it, that just means you really should be doing it.
let's get Heinz to jump in. Heinz, go ahead and unmute and ask Dr. Anahita Dua your question.
Hi, doctor. Thanks for coming on today. I got to give you a little background before I give you my question. And related to that, I already had stent, I had atherectomy and all that good stuff. Walked fine. I'm walking 6 to 7 miles a day. After or before the last treatment I got a year and a half ago, I had neuropathy on my foot. And it's only one leg, one foot. And then with that, my dog's going nuts. Sorry about that. With that, recently I started during my walks, my foot got a little more pain, neuropathy pain, and then also my shin, but not my calf. I had very little pain in my calf. I'm thinking, eventually either my pop artery or my SFA is giving out. So I'm just wondering, where all can you get claudication if not behind the calf?
Great question. Great question. I will say, a lot of patients have kind of the neuropathy. I mean, that's a part and parcel, unfortunately, of the kind of the diabetic sort of situation. People get sciatica sometimes as well, goes all the way up the leg. But the claudication in its classic sense is always the calf. You can get a little bit around, like, I wouldn't say the shin bone itself, but a little bit kind of surrounding, but it's really going to be that back of the, like, you'll be grabbing your calf muscle. So if you're feeling it in other locations, like I'll get patients saying, oh God, the side of my thigh really hurts. And usually patients like that, one of the things I say to them is, has someone looked at your back? Because neurogenic claudication, which sounds similar, but is actually a very different thing, is also getting kind of the same sort of feeling. However, it's driven by issues with either the back or the nerve itself that is not like appropriately firing. And so even if you have enough blood supply, that you're going to get this kind of crampy pain, and it might be related to that instead. And some of the things I tell patients to do to kind of decipher whether it's the back or it's the leg is I'll say, okay, if you go to the grocery store and you get a shopping cart and you sort of lean over that shopping cart to push it, can you walk for miles? And they'll say, oh, yes, and they think it's because of the crutch. It's not. It's because you're splaying your back and there's some compression going on. And so those are like kind of the little things that I'll ask them to do just to tease out what's going on. Then, of course, do their standard ABIs, which is that ultrasound test where you actually check to see what the flow is down there. But to answer your main question about, where else can you get claudication? I mean, claudication in and of itself can be anywhere. That just means that the muscle is feeling this stress of not having enough flow. But in the way we're talking about it with intermittent claudication for PAD, it's really going to be pretty specific to the calf.
Okay, thank you. So it could be something else.
Exactly.
But I walk enough where all of a sudden the pain subsides.
Which that was, that's interesting. Somebody else asked a question kind of like why is like easier to walk on the second mile, or why is it easier to walk later?
Yeah.
And usually that usually has to do with, now again, this is all typical, just standard, is remember in your legs, you have the blood vessels, you have nerves, but then you have muscle and bone. And it's not infrequent for people, like I'll get a patient that will say, in the morning, I just cannot even move. But then when I get going by midday, I'm doing okay. And usually that has to do with a kind of an orthopedic issue where like there's a little bit of joint stiffness, and that's what's getting, and that's also painful. You'll have the same sort of referred pain. You'll get it down your leg, but it really comes from the hip, or it comes up the leg from the knee. And it could be just osteoarthritis that has not been properly diagnosed, or is not bad enough for a surgery, but is causing you to have these issues, especially if you're, because remember, if I was an orthopedic surgeon, I'd be like, whoa, walking miles a day on your knee that has osteoarthritis, I don't like that, especially on hard terrain, versus a vascular surgeon is going to say, oh, all day long, I love it for the collaterals. So, the walking may be causing other issues, and that's why every patient's sort of a unique, independent patient, and having a physician guiding you is really important. You don't want to trade one problem for another.
And thank you, Heinz. And Marcia, I think that Marcia was the one that had the question that she was asking about, the second mile. Marcia, go ahead and unmute.
Hi, thank you. Yeah, I'm walking a lot right now, like a whole lot. And I go out every morning and walk and hike. And I was the one who said why is the second mile easier? It's almost, and I do have some osteoarthritis a little bit, but it's really in my right leg, which is the one that's blocked. It almost feels like it has to wake up every day, and like right now, I probably wouldn't have any claudication if I was out there.
Right. Because later.
But every day it's like, oh, here we go again. Like, it's the movie Groundhog Day.
I use that. I tell my patients like 51st dates. Same concept.
Right.
No, I hear that. I wouldn't be able to tell you if that was a vascular. I mean, and that's really what I'd say. I mean, have you had your ABIs checked? Have you had your flow checked?
Oh yeah, I have 100% blockage from my SFA down to my popliteal.
So there might be
popliteal or I don't know.
No, that's perfect. That's perfect. There might be something to be said about that, about getting things going. Though, the blood supply never really stops. It's not like at night when you're lying there, it doesn't flow anymore. Of course, to keep your leg attached to your body, you never want it to stop. But there may be something to that about just kind of getting going over the course of the day, that you just have to sort of get almost like a warm up, so to speak, like you were working out. And there'd really be no treatment for that the only way to do that would be to do a bypass or something where we'd now get more, but you're not going to experiment by doing that. That'd be crazy, especially since you don't need it. So I would say the good news about what you're saying, and that's what I always do when I approach a problem in medicine where like I don't have an answer for you. What I would say is, okay, what is it not? It's not the bad things. You're not going to lose your leg. You're not going to get gangrene. It sounds like you've done enough to get enough flow down. So even though this is a major nuisance, and it's been going on for so long that almost the time aspect of it is a positive thing, because it means that this is just going to keep happening, and versus you getting worse.
That's what I am very interested in, is if you slack off, like say I went a week or two or this surgery or something, could I end up with critical limb and cross that barrier? Like you said, there are two kinds of PAD. Can you cross like they didn't just wake up one day probably with critical limb, right?
No. Usually the patients will have what's called rest pain, which is literally while they're sitting there at rest, they have constant pain in their leg, sometimes changes to the foot where it's like very, very swollen or red and just very tender. And then ultimately they get a wound. But no, critical limb ischemia, so some patients are just walking around. So think of it this way. This is the best way to put it. Imagine that you have a job where you have just enough money to pay your rent and pay your groceries, okay? And pay your car payment. That you make just enough money. But one day you get into a car accident and now you owe money. Suddenly you may find out that you may end up homeless because things just go awry and you don't have enough money to get over that little hump, and things spiral. So there are patients that do have critical limb in the sense that they don't have enough blood flow to get into that car accident. They have enough blood flow to keep their leg attached to their body, for it not to hurt, and for them to just do their general activities of daily living. But if little grandson comes over and runs over their foot with a Tonka truck and they get a wound, that's their car accident. Now they're not going to have enough blood flow to heal that wound, and they flip into critical limb ischemia. So yes, they were sitting like that, like they were always like one paycheck away from that. But then if something happens, they walked on the beach without, and then yes, there is a substantial proportion of people where they spontaneously develop wounds. And then of course there's the proportion of people that really go down, their pain gets worse, they're still smoking, and then eventually they get a wound and it's spontaneous. Maybe the shoe rubbed them the wrong way, something like that. And then the wound just won't heal. And that turns into gangrene, and that turns into et cetera, et cetera, et cetera. And that's why catching it early is so important. So you can have, and the best way to know that is that all of you should have, if you have PAD, should have had ankle brachial indices checked and a toe pressure. That's the name of the game, the toe pressure. You want that toe pressure greater than 55, especially if you're a diabetic. Just because it's lower than that doesn't mean you run off and get surgery, but it does mean you got to watch out. If you have a toe pressure of 32, let's say you personally, if you have a toe pressure of 32, now we know you have that blockage. Okay, but you're living your life. You're not in pain. It isn't a cancer, so it's not like just because we found it, we need to fix it. But let's say your toe pressure is 32. It's not that 55. Okay, I, as your doctor, are going to say, Marcia, you just got to watch these feet. I want you in diabetic foot shoes. I'm okay with you walking. I'm okay with you living your life. Build those collaterals. But if you get even the hint of a wound, I need to see you, because we may need to do a bypass on you, or we may need to open up that blood flow, because that wound is not going to heal and it might turn into something grander. And that's why having that vascular specialist in your back pocket who knows you, who's guiding you, is so
Right.
important.
Well, that's actually, it makes me feel a lot better because I'm so afraid to go into CLI, but I've never had a wound and I walk all the time. So thank you.
Now, Marcia is just one of those dream patients, and I had the blessing of being able to be on the phone where she met with this vascular surgeon because she was referred over to him for a bypass. And it took, maybe a month or so to get into that appointment. And meantime, we were like, okay, you got to walk, walk, walk. Let's push through it, Marcia. Let's push through. And she goes in there and he's like, I don't need to see you. Look what you did. I don't need to touch you. And it was amazing.
That's a good surgeon, that's and that's the way it should be. That is the way it should be. The day may come, but you don't blow all your money in one day. Someday, and it's not people's fault. I mean, there's a genetic component to it. Absolutely there is,
Yep.
So that's really kind of key. You really want to have that person there with you. And we're lifelong, we don't go anywhere. We are with you. You may not need us for 2 years, 3 years, but eventually it's something that you just need to have in your back pocket.
That's what my doctor told me, my interventional cardiologist. He said we were in a long-term relationship, which I didn't know going into it. I had no idea, but we are. Thank you.
Insurance company knows.
Yes. And we have a couple more questions here, Dr. Dua, if you don't mind. I think 3 more questions. We have JR Coates that wants to jump in. JR, go ahead and jump in,
Everyone.
unmute. Thank you for joining us, JR.
Can you hear me?
Yes.
You can. Hi.
Okay. Yeah, I just family doctor up in Canada.
Hi.
And really enjoying your presentation. I wondered, what would you say are the biggest barriers to patients recognizing PAD early enough to prevent its progression? Wonder about its insidious onset. And if we really don't know what's happening in asymptomatic patients, who would you screen and how would you screen? Is ABI effective, plus or minus arterial Dopplers or toe pressures?
That's a fabulous question, actually. So you're the crux of stopping the patient. We see them at the kind of the end stage. Many, it's total Swiss cheese. Many opportunities to have stopped it, but we get them, all the way at the end because it wasn't stopped. Actually, I know you're up in Canada, but we're actually trying to get this bill passed called the ARC Act, which is the Amputation Reduction and Compassion Act here in the States, which will reimburse. Part of it is reimbursement for our primary care doctors to do PAD screening on patients and specifically do ABIs on them and reimburse for the ABIs so that we get them earlier. I would say at the crux of it, specifically for your diabetics, your hypertensives, and your smokers, and certainly the combination patients, all of them should be screened specifically with 2 things. Number 1, they should all have a pulse examination. And basically, if you cannot feel pulses on the patient, they should get ABIs, but with the toe pressure. So back in the day, our grandfather's PAD patients, they used to have disease in the tibial vessels, which are the vessels between the knee and the ankle. And in those patients, those are the ones getting the bypasses and getting the rotor-rooting and all that stuff. But nowadays, because patients are living so much longer with diabetes or even as smokers or whatever, the tiny little blood vessels in the foot, the microvessels down there, are getting obliterated. And so what ends up happening is the patient will show up with a little wound on their toe and have a toe pressure of 0. So they're never going to heal that. But their actual ABI, the flow at the ankle, is 0.7. Which is amazing, which means that there's nothing going on. So those are the patients that you really want to catch early and get them in to see a vascular specialist, because now we actually have therapies that could help a patient like that. But even before that, and they may come in completely asymptomatic. They may just have diabetes, and not even uncontrolled diabetes, just diabetes, but they've had it for 50 years. HbA1c of 6, but had it for 50 years. And those are the types of patients, the same way that they get their eye screening, they get their creatinine checked, they should all get their toe pressure. And for PCP, primary care, having a machine in your office is probably the best way to do it. And if you want a poor man's sort of check, the best way to do it is put a pulse ox on the patient's big toe, because technically the pulse ox should be the same in the toe as it is in the finger, right? And if it isn't, there might be something going on. It's just, it's not going to replace ABIs or toe pressure. It's just that, hey, for whatever reason, I'm only getting a 50% reading in your toe, and your pulses are diminished. We need to potentially get you to a vascular specialist early, and then at least they're plugged in. Then they get their formal testing. And then the vascular specialist may say, you're good, I'll see you in 5 years. But at least somebody has checked to make sure that these patients, and actually it's funny, you know, about that ARC Act I was talking about, that's been kind of the argument against it, that people are saying, well, you know, there's really no data that says that screening patients is going to somehow pick up this group. And that's got to do with like who we're screening and the heterogeneity of the population. And no one's really like looked specifically at like timeframes and stuff. And then the other piece of it is, if we're going to reimburse for it, you know, there's an argument that, oh, the PCPs are now just going to screen everybody every time they come and ask for reimbursement for it. So we have to put some guidelines in the bill to say who, what, where, when, why. And we've done that. You know, a diabetic, and then when we've done the same thing with aortic aneurysm screening, the same thing with carotid screening, there's no reason why we shouldn't be doing it for PAD.
Thank you so much, Dr. Anahita Dua. We really appreciate you. Congratulations being our first person that we are recognizing in the Global PAD Impact Awards for 2024 Best Educational Video. Walking is Medicine. Make sure you go to youtube.com/The Way to My Heart. Look that video up. 22,000 views on it. Lots of comments. Really powerful. Proven patient outcomes based on that video alone in helping to improve circulation. So congratulations, Anahita Dua. Doctor, we really appreciate you so much. She has to jump because she has gotten a call to go save some piggies, and we don't want to delay, and we really appreciate your time.
Of course, it's absolutely my pleasure. If any of you ever need anything, call me anytime. I'm more than happy. Me and Kim are great friends, so she can always connect you anytime if you need anything.